Hello, good afternoon. You're very welcome to the HSE's first staff webinar of 2021. 1,100 people have registered to join us this afternoon. It's the largest number that's joined for any of the staff webinars since they began last year. It's an opportunity to hear from the senior leadership of the HSE and to ask them some questions. And first, maybe I'll ask our speakers here to introduce themselves, starting from Colm.
Colm Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer.
And Paul Reid, CEO at HSE.
Okay, so you could put questions into the chat function on WebEx. By the way, I'm Mark Brannock. I'm the new National Director of Communications here in the HSE. I've only been here 3 weeks, so I'm looking forward to learning quite a lot here this afternoon. So firstly, maybe I'd ask Paul Reid our first question, maybe to give us a broad update on the position in our hospitals now and in our community services now and in relation to the virus generally.
Yeah, well, I guess if we just explained what's happened since Christmas. And firstly, I just do want to wish everybody who's tuned in a happy new year. I know it may not feel like it's very pleasant, but I just do want to wish that to people in advance. I guess it's just to take stock in terms of what happened over the Christmas period. And what we saw there was a combination of all of the worst scenarios that we could have wanted coming together. So we had a high growing number of cases, growing at a rapid rate, high positivity levels of transmission within the community, high numbers of contacts that people had throughout the Christmas period, it all coming together over the days after Christmas and New Year. And layer on top of that, which is a bit of the unknown still at the moment, was the impact of the variant from the UK. So all those multiplier effects came together in what I've described as an explosive manner. And we saw the impact post-Christmas in terms of hospitalisations, indeed ICU. Where we are now, right now today, as of this morning, 1,950 people hospitalised through COVID. And in terms of our ICU, 214 people with COVID in our ICU. We have gone into national surge capacity in our ICU. We've almost 330 beds now open in our 334 beds open in our ICU, and we do know when we get to 350 beds, we are at the max of our surge, and we then do move into other levels of care to support that as well. And so we don't really want to get there today. We've about 22 right now, or 22 ICU beds available. So many people who are tuned in are working on those frontline services. I want to thank them obviously, but we are seeing it's a high level of concern for us what's happening in our hospitals. It's not just on our hospitals, it's the impact in our community. It's the impact on our nursing homes and long-term care facilities and all of our community services. But it's equally an impact on our staff. As of today, we've about 6,500 of our staff who are out through either being a positive case of COVID or having been a close contact. And that's had a major impact for us.
Yeah, I suppose before Christmas, there was obviously concern that case numbers might rise, that hospitalisation numbers might rise, but nobody obviously predicted that it would get to this stage. What happened in the intervening period, do you think, that made it get to this level?
Yeah, I mean, there's some discussion about the impact of the variant from the UK, and certainly we know that it accounts for, well, at least over 50% of the cases that we're experiencing. But it's not proven yet if that has higher transmission levels or whatever. But I think, as I just said, I think the impact has been the explosive nature of all those factors coming together. Many contacts, high growing cases, high positivity, high transmission levels, many of us meeting over the Christmas, and it all culminated together in the worst concoction you could expect.
Yeah, and could I ask Anne O'Connor a question that's come in from a number of staff, which is that, like, we've seen the third wave really affecting staff. There's a very substantial number of people unable to work due to being COVID positive, due to being in close contact. A lot of staff have been asking, with concerns about the derogation of staff that have been close contacts, have we had to do this yet? How is the process managed?
We have, and hello to everyone today. We have had to use it, yeah. We have a significant challenge, as Paul said, in our acute hospitals and critically across all of our services. So I think at this stage, it doesn't really matter where you're working. You're probably feeling under immense pressure in terms of the demands that are coming at you from all sides, probably. And I think what we're seeing is a whole system response, but equally a whole system pressure in terms of individuals feeling like they're being asked to do a lot of things in a very difficult environment. So from our perspective, the staff derogation is important. It's something that we use as, I suppose, a measure of last resort only. I think, the staff derogation is one of these things that we can debate the pros and cons, but critically we know that in environments where there are significant challenges, either related to outbreaks or related to just, anything else that goes on in a healthcare environment, having a reduced number of staff available creates risk. And I think we have to balance that risk with the risk associated with bringing somebody back to work who has been a close contact. That is something that's managed at a local site level. It's overseen by service managers. There's a very strict rule set around it. And we have had to use it on occasion. Not on too many occasions, but certainly where there's a risk of us being able to actually continue to run a service, we have had to bring that into effect. So it is something that we have used.
And obviously the third wave, if you like, has been more severe in its impact on the health services, hospital services, community services than the waves last year. Were there learnings from what happened last year that we have put into practice, if you like, in the third wave that have helped us deal with the recent crisis?
I think there's huge learning from the first and second wave, and it still didn't really prepare us fully for what we've experienced in the third wave. I think this particular wave, and certainly the experience since, before Christmas really, has been unprecedented in all sorts of ways. I think the learning for us has been really to allow services to do what they need to do in terms of reacting in an agile way. It has been about us trying to allocate resources to where they are most needed and to support our whole system. So in terms of the community, developing its capacity to support the acute hospital system in terms of preventing admission, supporting egress, etc. And critically looking at those other services that aren't in that direct pathway between home and hospital. So the services that are out in the community, supporting homeless people, supporting people with disabilities, people with mental health problems, looking at all of those different services and how they can continue to work and how we can continue to support staff. I think important to reference that we know there are lots of outbreaks in some of those settings too, and people are feeling very challenged in terms of how they prioritise their workforce, how they prioritise their work. But I think certainly in terms of the impact of this on people and critically on their psychological well-being, we have developed a framework in terms of psychosocial supports for staff. And many of you will have seen a broadcast that went out about just the different supports that are available. I think, we can't underestimate the impact that this has on a personal level for people. You're at work dealing with this and you go home and you're still in a COVID environment effectively in terms of within your community. So I think it's really important and something that we've put a lot of time into with a group of very experienced people around the organisation, just looking at that framework for how we can provide essential psychological supports to all of you who are working under immense pressure. So really the learning for us is to really watch out for people in terms of supporting all of you who are working and really creating those different mechanisms to support you either online or in other ways. And I would urge any of you who feel under pressure to look that up. So I think, Mark, there's been a number of different things, and certainly our health service is about people. It's about the staff that we have working in our services, and without all of our staff, we don't have a service. So the learning for us is really to focus on that as well.
Yes, maybe a question for Colm Henry. The staff in many places around the country are reporting that within hospitals, people who are being admitted tend to be more sick. There tend to be younger people. Is that a substantial phenomenon around the country that we can say, yes, that's absolutely true? And if so, why do we think that's happening?
Yes, we get that report from hospital staff in particular. They notice different patterns. And as a hospital animal myself, I know that you tend to see things through the prism of illness as it comes through the door. The fact is that there's what we've seen, that word unprecedented again. We've seen unprecedented levels of disease and infection in the community. So if enough young people become sick with COVID in the community, eventually a number of young people will need hospitalisation. And eventually even a subset of those will require critical care. And sadly, even some of those may die. So what we've seen, the patterns of illness we've seen this third surge reflect the huge amount of infection in the community that we've seen since Christmas. Somebody said earlier on in this pandemic that the virus makes fools of our plans. It makes fools of our performance tables as well. If you look, it's only a few short weeks since we were the second best in Europe in terms of 14-day incidence, and now we're in the second. Although we're beginning to improve, we're second worst. So what people see in hospitals is the tip of the iceberg. It's those people, the huge mass of people, the thousands who are becoming sick in the community, an average still at over between 2,000 and 3,000 per day. And remember, at the beginning of December, it was 400 per day. So a subset of those, we know for every 1,000 people who become infected, about 30 to 50 require hospitalization, and between 3 and 5 may require ITU. And those ratios have held very true right through all these phases. What we saw, Mark, in the second phase was a predominant surge in younger people, which tended to protect our hospital system, and a late attenuated surge in older people. But this surge has been characterized by all age groups, including older people. That's reflected in the quite precarious state of pressure we see in our acute hospital system today.
Yeah, and as you say, there's a huge amount of attention being paid to the numbers in ICU and the level of ICU capacity, while the reality is there's huge numbers of people who are very sick and aren't in ICU. In terms of ICU capacity, and I see a question coming in there now, how many critical care beds are planned now to be added to the system over the next period of time?
Can I touch on your first point first, just to acknowledge, of course we function in ITU and it's understandable, I'll come to that in a second, but I want to acknowledge the huge suffering that takes place in the community from people becoming sick with COVID, including in healthcare staff. We all know somebody who's had this now, young and old, and it is a horrible illness when it affects you the way it affects in its most severe form, which unfortunately happens more frequently than flu and other viruses. So we have sick people in the community, people who are managed there by general practice, which itself has been under stress. And we have many people in our hospital system who are being managed with supplemental oxygen, with non-invasive ventilation outside intensive care settings. Over 200 on any one day over the past few days. Looking at intensive care, what we did, and the question came of what plans we made over the past 11 months, what we did was we built up, first of all, working with the critical care program with clinicians. And when I say clinicians, I'm including the critical care consultants, the critical care nurses, in training staff up for redeployment should we need a surge. And in parallel with this, we created an extra critical care capacity building from our baseline of 255 beds to about 286. And it's thanks to that work in the additional core capacity, but also in creating this surge that we find ourselves today in being able to provide critical care to an unprecedented number of people. That's over 200 with the same illness. That's never happened before, requiring critical care, not just in those core critical care units, but outside by people, and I have to give, again, huge acknowledgement to those staff who've been trained, redeployed, providing critical care, ensuring the best possible outcomes, working hand in hand with their colleagues in critical care work there all the time. We're well into that surge now, at the end of the second week into that surge, and the question is now whether the ongoing number of cases, which still amount in the community to over 2,000 per day, whether that will place additional stress on a hospital system that's already under stress. But I can't acknowledge enough the huge work and the degree of fatigue that our hospital and other colleagues must be feeling under these current pressures. And hopefully there's a turnaround we're seeing now in community cases. We're seeing some positive indicators and a lower number of positivity of tests, a lower number of close contacts for every case identified in the community. But there'll be a long tail to this before that plays through our hospital system.
Paul, did you want to add something there in relation to ICU?
Yeah, and I just see another question come through later, but yeah, Colm's given the figures. We are in surge capacity. We have, as part of our winter plan as well, to bring on 16 ICU beds to bring our baseline from 285 to 301, so that brings it up. And then a further 20 beds for next year to bring it to 320 of a baseline. But we are, as I said earlier on, we are at 335 today, which is surge and redeployment. We want to build that base stronger, and that's where we are today, 22 ICU beds. And there was a relative question, I think, just flicking through on the chat there around suspending or non-urgent care and the decision around that, which is related to ICU. It's not a decision we've taken lightly. It's a decision that we had to think through very carefully, but looking at what was happening in our hospital and our ICU, we had to make the decision to pause non-urgent care. And I know the impacts of it, and I know the impacts on our staff, but it was the right decision to do based on where we saw the ICU capacity going right now, today.
Okay, one question, and variations of this have come through from a number of people, but and it's asking you to look into the future to an extent that people are asking, when and how will this end? And obviously we can't answer that, but how would you see the next few months, the next year even, playing out towards normality at some point? And I'm not sure which of you would like to take that first.
I think, unfortunately, none of us know. We don't have a crystal ball that can tell us all of this. But I think, as Colm said, if we can see a reduction in cases, I suppose from a health service perspective, we're under huge pressure. You'll all be aware of that. We have many staff out, as Paul said. We need to get people back in to be able to actually continue to provide services. And I think, at the minute, the focus is very much on the services for people who are COVID positive. But we know that our health service has to provide so many other services, and many of those have been scaled back, as Paul said, the cancellation of electives, but equally in the community, the reprioritization that's gone on. And we need to start getting back to providing those services, a bit like we did after the previous wave, where we had a whole approach to service continuity, and we've been reviewing that. So we will have to start turning back on services over the coming months. So there's an element of deja vu here in terms of, winding services down and winding them back up. But unfortunately, that's where we're at. I suppose the real difference this time is that in parallel, we have a vaccination programme underway. And I think that's where the real light at the end of this tunnel comes. So from a health service perspective, we will do what we do. We will continue to provide services. We will continue to prioritise the people who are in most need of those services. And equally, we will seek to vaccinate our workforce so that we can continue to provide essential services. So I think, it's going to be months, not weeks. It's a long haul ahead of us in 2021. And I think we just, we know what to do. We just have to keep moving forwards, and we have to keep protecting our service users and their families, and equally all of our staff.
Which brings us, I suppose, to a question, again, a lot of people have asked, and Paul, maybe you'd broadly give us an update on where are we in relation to the vaccination programme?
Yeah, look, I think firstly, as Anne said, it is the one thing that gives us all a sense of light, inspiration and hope. And I think we are off to a good start. We are very limited in the supply that we are getting at the moment. We've roughly about one supplier, which is the Pfizer-BioNTech supply, which is roughly about 40,000 per week is what we've had for the past 3 weeks in particular. The Moderna vaccine, now approved by the EMA, now gives us a very limited supply in the first instance, but we expect to get those starting to very reasonable numbers in the next couple of weeks or so. And then we have the site of the AstraZeneca, which will go forward from EMA approval at the end of January. And we do expect early deliveries, which would be a significant volume and a significant way of changing the distribution and those people who can be vaccinated. So last weekend, our plan was through 3 mass vaccination centres, Dublin, Portlaoise and Galway, to vaccinate GPs and some pharmacists to start the rollout for the AstraZeneca, which will initially be to the population, the rest of the healthcare workers, but also to reach out to the public in terms of the 70 plus age categories. So very summary terms for myself, and I know people will be hearing many negative stories in the media in terms of our vaccine rollout programme. We are going at pace. We are delivering every volume we get every week. We prioritised those priority healthcare workers. The second week or third week, we prioritised nursing homes, long-term care facilities, residents and staff in the nursing homes in particular. And we will go back now to the remaining priority healthcare workers, and then indeed to the next cohort as well. So we're off to a start. It's limited by supply. I appreciate the frustration. If we had 500,000 vaccinations last week, we have 500,000 people who want them. But we will get there. And this will be the one thing that changes the whole public psyche and gives us all a better hope in the future.
Yeah, and we do see from social media, from national media, and from many of the questions that came in here today, a lot of staff expressing great joy and delight and relief at having got their vaccinations, and staff expressing frustration and upset that they haven't yet got their vaccinations. And the reality is, I think we have some of our staff working side by side, some who are vaccinated right now, some who are not, which I presume is a function of the supply. When will that issue be resolved satisfactorily, do we think?
Yeah.
Well, first of all, we want to get to all our frontline staff, be they hospital or community, as quickly as possible. The only rate limiting step for us is securing the vaccine deliveries currently with Pfizer and then Moderna, and the secure deliveries we have, like other European countries, is limited for the foreseeable next few weeks. In line with NIAC, for those of you who aren't familiar with NIAC, the National Immunisation Advisory Committee, they laid out a series of priorities, and the priorities were based on where the vaccine would have maximum effect. We know the vaccine from evidence reduces the chance of serious illness among those people who contract the virus. And for that reason, NIAC, and it is an agile document because we'll be learning as we go along, have prioritised number one, older residents of long-term care facilities and healthcare workers there, and number two, what are called frontline healthcare workers. And we've issued clear guidance, working with Martin Cormack and his team, as to the different categories of workers and how they would be categorised in terms of prioritisation. In other words, people who work with patients in COVID wards or in COVID settings or in what we could call uncontrolled settings would clearly have priority. Now, of course, there will be some unevenness because when we were starting the programme, we started in 4 hospitals. Then we trialled out in a hospital group over bank holiday weekend. And then we went through all our hospital groups. And then in parallel with that, we asked the hospital groups to reach out to the community, to community healthcare workers. What we want now is, once we finish this exercise in residential care settings, that once we get those secured stocks in February, in early February, to focus again using our framework of prioritisation as to who constitutes what priority, no matter where they work, to target those priority healthcare workers, either using our hospital facilities to administer the vaccine or using other facilities. So we will get there.
How will individual staff know they're going to be vaccinated, whether they're hospital staff, community healthcare workers or whatever? How will they know that that's...
We're working with closely with Anne and David Walsh and Yvonne and other people, and in the hospital sector, Liam Woods, to identify obviously the staff who already received the vaccine, and also to identify where each staff fit in the prioritisation schedule. So we can then give them some idea of what category they lie in. But the ultimate scheduling will depend on when we get secured delivery of doses in February, and then we can resume the priority healthcare workers.
Okay, and staff who may be reluctant to receive vaccines. I read somewhere recently that is a very, very low number, but if there are staff reluctant to receive vaccines, what do we say about them and to them?
Well, there's no compulsion. As we know, during many annual flu vaccine programs, we've greatly encouraged staff to get flu vaccines, not just to protect themselves, but protect the people who they care for and their services. And we've seen huge improvements in the flu vaccine program over the years, from a baseline of 25% some years ago to now, I think it's 60%. But there's variation there. Some places do better than others, some hospitals do better than others, and so on. So there's no compulsion on people to get the vaccine. But based on the uptake we're seeing, the enthusiasm, the energy, the volunteerism to help out administering the vaccine, we see very few cases of people refusing to get the vaccine. And I think that's because people recognise what the vaccine does. They feel assured by the evidence to date. And they see how it might allow them not just to protect themselves, but protect their patients, and also protect the services they work in.
I saw the phrase queue jumping coming up on the chat there, which is something which is talked about an awful lot. What do you do to safeguard the priorities? You know, vaccinations are being administered in a lot of different locations, in a lot of different parts of the country. What can you do, and what can individual staff do? Maybe Paul, to make sure that this is seen to be done properly and seen to be fair.
Yeah, and I'd like to frankly just address up front, some of the issues that emerged in the media this week, because we should talk about them openly. And first of all, there's many frustrations across staff because and sometimes it's a perception. Somebody in admin has been vaccinated before somebody in frontline. And as people who know and work in our services know, many people who work in admin can work patient-facing. So they do need protected as well. They do need to be protected. The second thing that emerged this week was a lot of media frustration and reporting around people being vaccinated in private hospitals. And again, I want to address that one up front. The sequencing that Colm just referenced doesn't distinguish between people in public and private, because many of our patients are being treated right now today. This week, 900 of our patients are being treated in private hospitals as part of our agreement. So, private healthcare workers do have to be vaccinated too. And then the third issue that emerged this week, I'd like to take head on as well, is where it has been seen and reported that there has been some family members who do not fit in with the sequencing being vaccinated prior to staying with the sequencing, if you know what I mean. And I just wanted to address that first up front. Firstly, there is an understandable drive to make sure no vaccines are wasted in a vial, and there is a short duration in which you have time to do that. So I fully acknowledge that. However, there can be no reason why it did end up with some family members who do not fit the sequencing being vaccinated. That shouldn't have happened. I don't condone it, and it shouldn't have happened. And I don't think there could be any rationale that says we are waiting clarity. The clarity is there from the start. However, Colm, Chief Clinical Officer, has circulated further clarity around the sequencing within each cohort on the 12th of January, and that's now out there. And it does set out clear guidelines when you're preparing for the vaccination to prepare at the end of the day that you have a standby group of people. If somebody doesn't attend, or you have extra vaccines left in the vial. So I hope I've tried to address upfront the issues that emerged this week, and that's where we stand on it.
Okay. Concerns being expressed about the new strains of the virus, and they're being expressed in two respects. One, about whether new strains mean that the social distancing rules and the safety rules should change or be modified in some way. And the second concern people have asked is about whether the vaccine will be effective, whether we know the vaccine will be effective against the new strains that are out there now. Would that be for you, Colm?
So first of all, there are three strains we know. It's not unusual for vaccines to mutate. They happen, or viruses mutate. They mutate regularly, and most of these mutations don't have any significant clinical consequence. The three that we're concerned about are, first of all, the UK variant, which is referred to, and we know that it's from where it started in London and the southeast. It quickly became a dominant strain, and it's now the majority strain in Ireland. We know that it's much more transmissible. There's no evidence to date that it produces more virulent or more severe disease, and there's no evidence to date that it's resistant to those antibodies which are produced either by illness or by a vaccine. So that's of some assurance. But what is important is it should act as a reminder to us that how we already knew this virus was very transmissible. Now we have a version of it that's even more transmissible, and that's the reaction to that is a double up on the measures that we know work: the social distancing, the hand washing, the diligent, the appropriate wearing of masks in the settings prescribed, and also the societal measures which are put in during the current surge. That's what works, and that's what limits transmission of this particular strain. The other two strains that people may be concerned about are the South African strain and the Brazilian strain. And three of the South African strain have been identified in Ireland, none of the Brazilian strains to date. Equally, they carry concerns of being more transmissible. But again, no evidence to date that they're either a more serious illness, or they affect different groups, or that they're more resistant to the vaccine when it comes out. But it's a reminder that we're dealing, as I said at the beginning, the virus makes fools of plans, it's made fools of countries. And it's been a very long 11 months, and even 1 month is a long time in this virus. And there will be more mutations. And who knows what we'll be talking about in a few months' time. But right now, what we do know is it's very transmissible. The new strain is even more transmissible. It calls on all of us to double up on the measures we know work. And we know that the vaccine that we've developed and the vaccines in development at this point in time are effective against these strains. So we work on that presumption.
And Paul, when we get to rolling out this vaccine to the broader population, obviously we've talked about mass vaccination centres. Are we at any stage where we can say how many there will be? Will they be very large and a small number? Will they be smaller vaccination centres, but a larger number around the country? Have we any thoughts on how that will go?
Yep, we're getting closer to be able to very publicly communicate about this. There's a lot of work going on right now with our estates, HSE estates management teams, bringing plans tomorrow Friday, myself and Colm and Oliver's team working on this and Anne. I think it's safe to say a couple of things. First of all, there will be mass vaccination centres distributed all across the country. And I know Cyan there has asked a question in terms of southern areas. So they will be well distributed across the country, which will be multi-lane facilities with various supports around them. However, I think Ireland being Ireland and the nature of Ireland, we do know that regional and local works really well. And we've already engaged with discussions with the likes of the OPW, the local government sector, and various other government bodies and agencies about how we can maximise the distribution into local communities. And that can be a combination of using local facilities, whether it's community halls, we've had local hotels, we've had any amount of offers so far to help us with distribution, and we will be taking them up. So it'll be a combination of nationally distributed multi-vaccination centres, but I do believe there will be local and regional. And the power of Ireland is in the power of our communities. The communities galvanising, getting behind, getting people to vaccination centres, and galvanising the community to get vaccinated. So we want to tap into that great resource as well.
I see a specific question there about staff and about people generally who have a history of allergies, who may carry EpiPens. We obviously heard that the Pfizer vaccine may be problematic for them. What about the other vaccines? Colm?
Well, our vaccinators have undergone a programme of education based on each individual vaccine, which counsels them as to which groups the vaccine is contraindicated, and that includes people with a history of severe allergy. So anybody who is carrying an EpiPen for whatever purpose needs to bring this to the attention of the team and read the consent form and the information form that goes with it quite closely, and then, if necessary, seek specialist advice from their general practitioner specialist before they get the vaccine.
Okay. We've one question in from someone asking, with all the extraordinary amount of attention that we've had to pay to coronavirus, whatever happened to the flu this year, Colm?
Well, it was the ball bounced for us on a few occasions. It was a bit of a rugby ball this year because it didn't bounce that many times, but that was one time it did bounce, in that we knew early on that from the patterns in the southern hemisphere, which kind of lead the way with flu figures, that it wasn't a significant problem there. And so it turned out to be, both for ourselves, Britain and mainland Europe, that there was no significant surge in flu-like cases. And now there's two reasons for that. One is it just wasn't the year for a change, a mutation in the flu to cause a trouble. The vaccine, of course, and the role of the vaccine may have helped blunt whatever few cases emerged. But I suppose the third contributing factor was the fact that all our new behaviours of not shaking hands, not hugging each other, not hugging strangers, and staying away from each other, and social distancing and all that, meant that we saw a general reduction in communicable illnesses all around. It's a very heavy price to pay for what we have to do.
Yeah. I see another specific question coming in about access to the vaccine. When we are doing the older population cohorts, but the people who live at home, many of whom may not leave home that much, they may not be online. How will those people be vaccinated? People who won't be able to book online, and will this be something for you? People who won't be able to book online, people who don't leave home too much. How will they be vaccinated? What will they be asked to do?
I think in terms of people who are, I suppose, more vulnerable, be they an older population, and that's not to say that all older people are vulnerable, but older people are people who have other conditions. The GPs and pharmacists will be key here in terms of reaching out to people. And we've seen that in the flu vaccine, for example, where they've called in people for their vaccinations, and we would expect something similar to happen. So I think that community piece is going to be critical in terms of people being vaccinated. So where people are able to book and to access the system themselves, but we will rely hugely on GPs and pharmacists for people in communities who we know will need additional support to be able to access the vaccine. Okay.
And obviously, as we cope with this health crisis, there are people throughout the HSE getting on with business as usual as well. In relation to the service plan for 2021, I know it's with the subject of discussion between HSE and the Minister's Office and so on. Where are we now, and are we likely to see it soon?
Yeah, just to confirm, for the second year in a row, we got our submission back to the Minister within the 21-day timeframe, which was back towards the end of November. And obviously the Minister has not been long in position and post, so wanted to give that due consideration, which she did do throughout December. We got some further feedback on the service plan back to ourselves, and we brought it to our board just last week. And it's been resubmitted back to the Minister. which we expect to get the sign-off and publication of it within the next week or so. So it should be public. But just to say to everybody, I don't think, and everybody's well familiar with it, we are still getting on with delivering the service. I think the service plan and the budget for next year is something that we are really grateful for. A 21% increase in the budget for health spending of 21 billion, now of 21 billion euros, from just over 17 billion euros. I think demonstrates a couple of things for me. First of all, it demonstrates a very strong level of confidence in government, our funders, for what the health system has done last year and this year now in terms of managing this pandemic, what our teams have done. And I do mean that very sincerely. You have given great levels of confidence to help me and the team here make the case to government for further funding. So I think it is that. And secondly, the funding helps us now to consolidate a lot of what we've put in place during COVID. So what Anne was talking about, a lot of community services to protect and reduce the numbers of people that have to go to hospital for care. A lot of the work we've done with GPs in terms of access to diagnostics. A lot of the work we're doing now with private hospitals to increase our capacity. But a lot of work equally in terms of increasing our capacity in our hospital system, both in terms of ICU beds, general beds and step-down beds. So I think it's a great reinforcement that everybody should take great credit for to secure that budget when every other department and sector is under massive, significant pressure to even sustain the budgets that they had.
I suppose this is probably quite a challenging question, but if we got this very substantial additional budget for this year, so if in 12 months' time we were hoping to be able to tell our staff, the general public and the government, here's what we did with that budget, here's why that was a really good thing to do, what would you hope to be saying in 12 months' time?
I think what we'll expect to be saying and what we will be expected to be saying is the service to the public, which this is always about, as Anne described. People who are using our service, our patients, it has to be about them. And the first thing what we will have to be able to say is we have managed during this pandemic to run literally a dual health system. So managing to protect people who need to come to our services for non-COVID services and give them the level of service that we want to give, and equally to have a parallel service that manages COVID and protects the public and protects patients in terms of further transmission of COVID. So that doesn't mean actually we can lob on a whole lot. So first of all, it's to manage those dual levels of services. Secondly is to consolidate a lot of the investment we've put in place. So primary care services, GP is now being really part of the health system. Community assessment hubs that we've run during this one, being consolidated and being a new way of delivering services, mental health, disabilities. So strengthening the services to the people who are using it, but being realistic, we are managing a dual system for now.
Okay, and I'm seeing we're going back to a very specific vaccine question. I see a question from Claire Brennan asking something I've heard talked about a lot, that what's the current thinking on the vaccine in terms of does it prevent or slow down or transmission of the virus in any way? Is there a sense that we absolutely must continue to wear a mask afterwards because we're just as capable of transmitting it even though we're not going to get sick ourselves? Colm, what's the current thinking in relation to that?
So the evidence we have, the evidence we have that allowed the regulatory agencies, the EMA or the FDA in the US to approve this was based on those, what we call phase 3 trials. And they looked at tens of thousands of people. But like any vaccination program, a new vaccine, much more is learned as you roll it out in populations because you have much greater numbers. So what we learned from the phase 3 trials was that the vaccine was safe and that it was very effective at reducing serious illness from COVID in those who received the vaccine compared to those who received the placebo. Now, it stands to reason that it's more likely than not that will lead on to a reduction in transmission of the virus, but that's not proven as yet, and that will emerge in time. So the advice we're giving to people at the moment is that, first of all, it affords protection to those priority groups at an individual level. But then when you move towards saying, what does that mean for the general public? What does that mean for society? And this concept that we've heard about from the beginning called herd immunity, where a critical mass of the population have immunity of some type against the virus, either through natural means, having caught it, or through a vaccine. We've still some time to go before we get to that figure of 60 or 70% of the population. And as regards the vaccine, we're not quite sure yet, but more evidence will accrue in time as to whether or not those people who are vaccinated themselves, there's a reduction in their risk of transmitting the virus onto somebody else. It stands to reason they probably do, but that's not proven as yet. So, but overall, it is good news on this vaccine in terms of what it does. That they're very impressive figures in terms of how much it reduces serious illness in those people who get it.
Okay, and Michelle Herity wants to know the evidence for that change we made of moving from having a 3-week gap between dose 1 and dose 2 of the Pfizer vaccine to a 4-week gap. What's the evidence there at the moment?
Well, this evidence did come. This came from NIAC, the National Immunisation Advisory Committee, who were independent and advised the Department of Health through the CMO, and they considered the evidence based on the phase 3 trials. They considered the fact that after the first dose, some immunity is seen after 10 days, but that based on the trial that there's a more substantive immunity 7 to 14 days after the second dose. But there is some immunity after the first dose. The lengthening out to 28 days is consistent with the terms of approval of the vaccine, and it's considered by NIAC, who've given us this advice, and we've now implemented it prospectively, I think, from last Monday.
Okay, there are staff asking us variations of questions about how we work now. That obviously over the past year has been a huge amount of people working from home. Wondering when this ends, will that continue? Will we see permanent changes, Anne, do you think, in the way people work within the health service, or do you think in a period of time it will slowly drift back to what the previous normal was?
I think we have seen that it is possible to work in a very different way. There's a balance to be struck, I think, and we are trying to support as many people to work from home as possible where they don't need to be in a workplace. But there are places where we need people to come into work too, and it can prove to be problematic where we're dealing with files, etc. So I think that we will continue to look at that and to, I suppose, maintain that level of flexibility. I think from a work-life balance perspective for people, it has been hugely beneficial for many people, particularly people who have to commute long distances. And equally, we know there are some people who are at home who would prefer to be in the workplace. So I think that, it's something that we will see over time. I think our priority has got to be to maintain a safe work environment for as long as we have to. I think after that, we have certainly learned a whole new way of working in terms of flexibility and supporting our staff to work in ways that are meaningful, where they can be more productive. And I think that's something that we will absolutely build on over the coming months. So I guess that's something that we have to watch, Mark, in terms of the months and years ahead. But I think we can never forget the lessons we have learned during this past year, and that we will continue to learn over the coming months.
Okay, I see a question here perhaps for you, Paul, that the COVID assessment hubs were very successful and proved very useful in the first wave. Is it a model that we could see as part of the health services into the future?
Yeah, I think we've seen peaks and troughs of the usage of the COVID assessment hubs. In the first phase, they certainly provided great benefit for us and GPs in terms of people who may have COVID but not needing to go to a hospital, but being able to go to a very safe and protected environment. And it did help our hospital system. The numbers did come down significantly, and we've seen some assessment hubs utilised better than others. We do have, as part of our winter plan, an investment in more COVID assessment hubs, community assessment hubs, and we are utilising them. We probably would have planned more usage of them based on flu and respiratory illness, over which Colm has just spoke, it didn't maintain itself to the same levels. But ultimately, the principle of putting a triage process, if you like, before the hospital system within the community is what adds huge value for us, whether that's in our primary care centres or whether it's in it, which had to be during COVID, community assessment hubs. But yes, part of our model. Okay.
There's a question funny about the language we use for staff absences due to COVID-19 and due to being close contacts, and obviously from the communications perspective, it's very important. And we have staff members saying that we're often slightly carelessly perhaps using the word absenteeism to describe people who aren't present for those reasons. And I presume that's not designed to suggest it's absenteeism in the old nature of the word.
No. I mean, I think we refer to it as staff unavailable for work or on COVID-related leave. So we count, if we're into counting, we count staff who are either positive or who are close contacts in one category. We count staff who are either cocooning themselves or staff who are caring. So we have different categories. I mean, our reporting on absenteeism is just a standard format, but within that, we have a category that is COVID-related leave. It's very specific.
Yeah. Okay. It's about a year, I think we're saying, Paul, you were saying to me earlier, since the National Crisis Management Team first met to discuss this. The three of you, like everybody watching, have been working extraordinarily hard, and I see that myself. This is only a really very small part of what you do, and tens of thousands of people out there are doing this very same thing. How do you deal with it? Paul, maybe that's you first. How do you deal with the stress and the pressure and so on? Is there something you do to shut down from it? From my observation, I don't think there is, but maybe you'll tell me there is.
Just two quick things before I come to that. I mean, first of all, this process is really valuable for us as a senior team to be able to engage, to be able to answer people's questions, and hopefully people do view it and view it afterwards. So it is important for us. Second thing, what you just said is, it's interesting. Next Wednesday will be the 27th of January, which was the day we convened the first meeting of our National Crisis Management Team. And on that day, or just before that day, the first two cases in Europe were identified in Paris and one in Bordeaux. And the ECDC had the risk assessed for Europe as moderate. So it's really interesting. Even that's only this day, this week last year. And look how quick it all happened after that. So just say that. Very quickly, just to answer your question, I'm intrigued lately that a lot of people are very forthcoming in telling me I look awful, I sound awful, and I look knackered. So thank you for all of that. Very kind comments. But I do have to take them serious, and we all do have to take them serious, all joking aside. And it has been draining. Look, I put it all in perspective. Number one, I'm coming to work or getting to work or working, which many people in the country now aren't. So that's important for me. And I always think people have lost their jobs. Secondly, in terms of, so put things in perspective is the first thing for me. Secondly, just in terms of, listening, I said it before, listening to family is important for me. And I'll be honest, I'm not the best at it at the moment. And I think I have to take stock, and I think we all do. Because of late, dealing with what we've had to deal after Christmas, plus the mass mobilisation around testing and tracing, plus the mass mobilisation around the vaccination programme has all come together. So I think we all just need to, but again, perspective, because for me, and many people listening, and we have today, my final comment, we have today a CNM2 from St James's, Bernie Waterhouse, at our press conference after this. And she's going to talk about her experience in the year. And that's what I think about, our frontline healthcare workers, people who have been dealing with the higher emotional aspect of this, dealing with patients and dealing with their families at the worst time in the family's kind of experience, or indeed that patient's experience. So I put it in perspective, I suppose, the best way.
Okay, and as Chief Operations Officer of the HSE at this extraordinary time, is your new dog ever taking your mind off the job, or is it 24/7?
I don't know, the new dog could be for sale soon. I think, no, I mean, being honest, it's really hard, and I don't think it matters where you are. I don't know that I'm talking to anybody at the minute that isn't exhausted, that isn't sick of this. And I think, as Paul said, it is about perspective, and it can be even hard to grapple for perspective sometimes. As Paul said, I'm acutely aware that I'm not out trying to keep a nursing home afloat personally. I'm not wearing PPE all day. I'm not doing lots of those things that many of you are. But I think that there are different demands on different people. And for me, I think I've said this before, I have to say I rely on my previous life as an OT in mental health in terms of trying to just build in different things around resilience, trying to switch off. It can be very hard to do that, but consciously just not responding to things, switching off, going out for walks without a phone in your hand, and all of that. And I think it is about connection. I think the only way that we can actually get through this is by connecting with people, and even that's hard. So there's no obvious way to do it, but it is about, all of those little things, again, going back to the mental health piece, the little things we need to do to mind ourselves at the minute. This will pass. We don't know when, but it will pass. And in the meantime, we have to focus on, exercise, diet, sleep, connection, things that sound very simple, but that are incredibly hard to do at the minute. So I tend to rely on, like Paul, just the distraction of family, getting fresh air, and an awful lot of rubbish on Netflix that I can't even begin to describe or justify. But there you go. No, I can't. But if anyone's watched Cobra Kai, I don't recommend it.
And Colm, any advice to share with people out there who are working 24/7 and dealing with pressures that until last year they didn't have to deal with?
Yeah, there's a different feel certainly to this surge. The first surge, I remember having a conversation with Anne into it, saying we're 6 weeks into this, we better pace ourselves. And that just seems so long ago now. So and that reflects everybody was feeling the same thing. This will pass, the summer will come, and that'll be it. And now here we are. It was a second surge. It wasn't so bad. There's a third surge, and you can see it in the public as well, and in our colleagues who are listening today, who are working in the front line. There's a fatigue, a weariness, but people know what the right thing to do is, but the excitement isn't there. It's a weariness. I suppose we have to have hope. The vaccine brings hope. And as to anything, of course, I feel tired like anybody else, but I suppose one of the things working in healthcare, you're always face to face with people who are much worse off than you are, and their patients either sick with it, and in my case, people I know as well who are working on putting on the PPE on and off, washing their hands 15, 20 times a day, and exhausted at work. So I'm kind of lucky that I'm working. It's not to say I'm not tired, of course I am, but there's hope.
Okay, maybe I'll just take one more question that's come in from somebody, a specific question, then maybe ask each of you to conclude briefly. Fiona Crotty is asking about outbreaks in mental health units, and when will the staff and residents of mental health units have received their vaccine? I suppose a first vaccine and a second vaccine. I
might answer that question and use it, Mark, as an opportunity to something I said to the staff yesterday in communication. So, as I said, once we get our deliveries in February, beginning of February, hopefully we'll be able to resume healthcare staff. We've sent out what we call a prioritization framework, describing staff in different settings as to their degree of exposure and how controlled the environment is. And clearly there's a lot of concern in outbreaks. But what I would say to people as well is we must remind ourselves of the limits of what the vaccine does at this stage. If you receive, as I said earlier, there's some immunity after the first dose, but the proven immunity doesn't kick in until after the second dose, and that's 10 to 14 days. So to be blunt about this, and it's an unpleasant truth, the vaccine rollout is going to have little or no impact on this current surge or on outbreaks. And is minuscule, whatever impact does is minuscule compared to the other measures we know worked, infection prevention control and the societal measures. That's what we have to lean into at the moment. The vaccine will in time afford protection, but not for the current surge.
Okay, I'm going to ask each of the speakers to give a final comment. Firstly, just to let you know that there will be a recording of this put up on the staff website in the course of this afternoon for anyone who either has missed some of it and wants to see it again, or has somebody they'd like to tell about it. So, but maybe just in the last few minutes, I'd ask maybe Paul, Anne and Colm if there's any final message or points they would like to make.
Yeah, just very briefly for me, obvious, said it at the start, say it again, thanks to everybody for what's been a really difficult year. Thanks for what you do every day, regardless of what role you play, you're playing a blinder. And then the final couple of comments for me is what Colm has said, this will pass. And our expectation is it will pass at some stage during this year. Certainly we will get to a level of normality that we're all striving for. So just to keep that behind us. And thirdly, what I do want to say to everybody is a lot of my engagements are with some of our key stakeholders, whether it's the Minister, the Taoiseach, government. And I know that we have put the health system in a much stronger position, in a much higher level of confidence that government have in us by the actions of everybody throughout this year. So I want to say thanks for that, and take great confidence in it. That's what is important for us too.
Okay, and Anne?
Yeah, I mean, like Paul, just to thank everybody again for their unrelenting work. I think, one of the things that I think we need to hopefully fairly soon get back to thinking about is all of the really positive and important changes that we've actually made to the health system since they started that we don't want to lose. We've referenced already the massive investment as part of the winter plan, as part of the service plan. We have, our enhanced community care networks coming in, our children's disability networks. There's a massive amount of really important change, the whole way, I suppose, in terms of our acute hospitals working, looking at, different ways for EDs, different pathways for front doors of EDs, all of this. And to me, that's really exciting. And it can be hard to think about those things and how significant they are. And I hope that fairly soon we get back to that. I mean, we're building on all of it. There's a lot of work going on around the winter plan, a lot of really significant change that I think when this passes, we can be very proud of, and we will continue to build on that to continue to transform the health service. So this is hard, but even in this hard time, we're putting in some very important building blocks that I think will make a huge difference. So really just to acknowledge all of the work that's gone on around that as well. So thanks.
Okay, Colm?
Just to echo the thanks to everybody. It will pass, of course, as people have said. And I think, too, we will all look back someday with huge pride. People have worked through this, wherever they are listening today. They'll look back with pride at the part they played in what was a once-in-a-lifetime crisis for healthcare and for the country.
Paul?
Okay, just one very brief comment, and it's just to urge people to not take social media too seriously, because if you're to live your life by what social media is saying, whether it's Twitter or whatever, I believe it's a false world, because there's a lot of criticisms, a lot of issues, and there's a lot of nonsense on social media. So I'd urge people not to listen to that, because the reality of what we experience is, I believe, we have strengthened the relationship between the public and the HSE. Yeah, and many of the letters I get of correspondence, I get many of the cards of good wishes, we send them out to the system. But it's a very different world than what you'd experience in social media. So take great stock. People are doing a good job.
Okay, I think with that, we just say thank you very much for joining us from so many places around the country. And from Dr. Stephen's Hospital, just a thank you to everybody for the work you do in different places and different services everywhere. And stay safe. See you next time.